Okay, I think we're ready to go ahead and get started again. Our next two talks are going to focus on efforts to combat HIV and AIDS in developing countries. The first presentation will be given by Anurita Baines, who is an international consultant focusing on HIV, AIDS, and Africa. She was formerly the assistant to the UN envoy on AIDS in Africa, where she spent 10 years focused on development, women's rights, and HIV/AIDS in Africa, and worked very closely with Stephen Lewis, supporting him in his role as the UN Special Envoy on HIV/AIDS in Africa from 2002 to 2007. Welcome, Anurita.
Thank you. I hope everyone got their shot of caffeine to get through the afternoon. As Rebecca just said, I'm going to focus my remarks on HIV/AIDS in Africa, and in particular the impact of HIV/AIDS on women. I want to begin by giving a really quick overview of the global picture, just so we're all on the same page. I'm sure it's a lot of information that a lot of you know, but I'll go through these slides quite quickly. So almost 40 million people, adults and children worldwide, are living with HIV. Last year there were over 4 million new infections, and almost 3 million people died of AIDS. Globally, women now account for 50% of new infections. Africa is the epicenter of the pandemic. You can see on the map, sub-Saharan Africa has almost 25 million HIV infections. More than 60% of all people living with HIV are in sub-Saharan Africa, yet the continent is home to only 1/10 of the world's population, and the numbers are increasing. Gives you a sense of the burden of the pandemic. Sub-Saharan Africa is the green portion at the bottom. There's no single African epidemic. There are variations between regions and variations within countries. You'll see urban and rural variations, for example. That said, Southern Africa is the worst hit. Here the epidemic is generalized among the population, and almost 50% of new infections occur in Southern Africa, which is home to less than 3% of the world's population. In Swaziland, for example, the top graph, national adult HIV prevalence is at about 43%. It's now at 33%. It was once at 42%. And you can see from the slide that HIV prevalence among pregnant women attending antenatal clinics rose from 4% in 1992 to 43% in 2004. In Lesotho, also in southern Africa, a very small country, much like Swaziland, surrounded by South Africa, adult prevalence is over 20%, and over 1/3, about 36% of pregnant women between the ages of 25 and 34 tested HIV positive. HIV/AIDS is more than a health issue. In southern Africa, social and economic indicators are being rolled back in country after country. We're seeing countries that once reached or came close to reaching development targets like decline in infant mortality, increase in life expectancy, increase in school enrollment. We're finding that all those targets are quickly slipping away. When you lose people in the prime of their life, as you do with HIV/AIDS, it strikes people in their 20s, 30s, and 40s, you begin to see the unraveling of societies. When you lose doctors, teachers, nurses, police officers, civil servants, and parents, you start to see communities and families fall apart. Very quickly on life expectancy, you can see I got the memo to include a graph on life expectancy in my presentation, like everyone else. As everyone else has said today, I think it's one of the most important graphs you'll see. It shows the impact of AIDS on life expectancy. In many countries in sub-Saharan Africa, HIV/AIDS is erasing decades of progress in extending life expectancy, and millions of adults are dying young or in early middle age. Life expectancy in sub-Saharan Africa is now 47 years, when it could have been 62 years without AIDS. And I think it's just to point out Zimbabwe, which is the dark blue line. Women have an average life expectancy of 34 years in Zimbabwe, and for men, they don't live past the age of 37. The World Health Organization says that life expectancy for women in Zimbabwe has fallen 2 years only in the last 12 months. So to get to the impact of AIDS on women, the situation for women in Africa with respect to HIV/AIDS is really one of life and death. This is where the feminization of the pandemic is most apparent, and gender inequality and our failure to respond to gender inequality in the region is proving lethal. In every high prevalence country, women are disproportionately infected by AIDS compared to men. 59% of adults living with HIV in Africa are women, and what's happening to young women in particular is pretty shocking. In the age group of 15 to 24, which I think is the age group that most of you as students here fall into, of all the young people who are HIV positive in that age group, 76% are young women. And if you look on this graph, the bottom half shows that women are disproportionately infected by HIV/AIDS, particularly between the ages of 15 and 24. What this means in this age group is that on average, for every 10 men who are HIV positive in sub-Saharan Africa, 13 women are infected. And in a country like Kenya, for every 10 men who are infected, there are 45 women who are HIV positive. A very recent report from South Africa found that death rates more than tripled for women between the ages of 20 and 39. The probable cause was HIV. Not surprisingly, there are countless surveys that show that young women don't know the basic facts about AIDS, that they're ignorant about how to protect themselves on HIV/AIDS. But I think it's important to remember that their vulnerability stems not just from ignorance, and it doesn't stem from their behavior either. It's not that women in Southern Africa are more promiscuous than men. It's important to remember that their vulnerability stems from their pervasive disempowerment. Many women have little or no capacity to say no to sex. They're unable to negotiate condom use in their relationships. This is an interesting slide. It's from a study from the London School of Hygiene and Tropical Medicine, which found that fewer than 7% of men, which is the purple bars, fewer than 7% of men used a condom in their last sex act with their main partner. There's an endless list of women's vulnerability. This slide is difficult to read on purpose. There are a lot of things on that list, and it's just to give you an idea of how sometimes it feels like the list goes on and on. Rape and sexual violence, marital rape, domestic violence, no sexual autonomy, harmful traditional practices, the practice of sugar daddies, illiteracy, lack of educational access, and the list goes on and on. Poverty in particular has put women and girls in a position to sell sex in exchange for goods. It's what's called transactional sex. Sometimes the sex is sold for some money or clothes, maybe a cell phone, but more often than not, particularly in Southern Africa, where food insecurity has been pervasive for the last 4 or 5 years, women are selling sex for food. They just simply want to feed their children and feed their families. The vulnerability of women is further exacerbated by unequal property and inheritance rights. Over 80% of farmers in Southern Africa are women. Women are the backbone of Africa's rural economy. They grow 70% of the food consumed by people in Africa, and they're responsible for half of the animal husbandry, yet women own 1% of deeded land worldwide. In other words, men own the land. In Tanzania, for example, and not unsimilar to many other countries in Africa, when village land was allocated, all rights were given to men, and no provision was made in the law for widows, separated or divorced women. In contrast, men are able to sell or rent their land without their wives' permission. In many African countries, women lose all rights to cultivate their husband's land and are literally driven off the land if and when their husbands die. I was in Zambia not long ago and met the director of an organization called Justice for Widows and Orphans, and they'd recently taken a case of a widow, a woman who had lost her husband, and the deceased husband's family was trying to drive her off the land and out of her home. They had come several times trying to take her home, and she stayed put and said, "This is my property, this is my land, and I'm going to stay in this house that's for me and my children." And because she wouldn't budge, her in-laws started burying dead bodies on her property in an effort to drive her away, because you wouldn't want to live near an area where dead people were buried. So they had They had buried 17 bodies on her land in hopes of driving her away, and she refused to leave, and she had contacted this organization to help her try and fight the case and get the land, to get recognition legally for the land that was rightfully hers. In a court case in Zimbabwe not long ago, the court unanimously ruled that a woman could not inherit her deceased father's estate. According to the judges, only men can inherit property, and they wrote, "Women should never be considered adults within the family, but only as a junior male or teenager. In a country like Lesotho, a woman can't open a bank account without the permission of her father. If her father is dead, she needs the permission of her husband. If she's not married, she needs the permission of her son, who might be 10 or 11 years old. And if there's no male member in her family, it's going to be a very long and difficult process to get something as simple as a bank account." Violence against women, or gender-based violence, is both a cause and consequence of HIV. There is a strong correlation between sexual and other forms of abuse against women and a woman's chances of becoming HIV infected. Condoms obviously don't mean very much if you're being beaten and raped, and also forced vaginal penetration increases the likelihood of HIV transmission. And the consequence part of it means that once a woman finds out she's HIV positive, she's often in danger of being abandoned or thrown out of her home. So she can often end up hiding her status and delaying starting treatment because she doesn't want anyone to know her HIV status. The World Health Organization recently put out a multi-country study on women's health and domestic violence against women report, and they found that worldwide, half of all women had experienced intimate partner violence. But in many countries in Africa, it's much worse. In Zambia, half of all women surveyed said a male partner had beaten them. In Harare, in Zimbabwe, domestic violence accounts for more than 6 out of 10 murder cases in court. And in South Africa, researchers for the Medical Research Council estimated that a male partner kills a girlfriend or spouse every 6 hours, the highest mortality rate from domestic violence ever reported. Yet few countries in Africa have legislation against domestic violence. From a recent study in Kenya, 49% of women reported experiencing violence in their lifetime. 25% of 12 to 24-year-olds lost their virginity by force. The Nairobi Women's Hospital receives an average of 18 cases of rape and incest each day, and there's one shelter for domestic violence in the entire country. Recently, a really fascinating study has come out of South Africa. It was conducted in Limpopo in a northern province of South Africa, done by researchers at the University of the Witwatersrand and the London School of Hygiene and Tropical Medicine. It's called the IMAGE study. And they set up a program. It's basically a microfinance or microcredit program, which I'm sure all of you know about. And the premise was that women would receive a small business loan, anywhere in the range of, it was 500 to 5,000 Rand, anywhere between $100 and $200. But in order to qualify for the loan, they had to attend regular workshops on gender issues. So they had weekly workshops which addressed various issues related to gender, and they were compulsory. You would only get the loan, and the loan would only be maintained if you attended the workshops. So what did they find in this study? Well, after 2 years, there was a 55% drop in domestic violence among the women who had taken part in the study. Quite interestingly, what happened, they believe, is that for the women, their partners suddenly valued their contributions to the household. They were now bringing in they were now economically valued by their partners because their economic status had improved. And also they believe that just the process of attending these workshops and doing it as a group of women on an ongoing basis led to greater self-confidence and just made the women feel that they had more control over their own lives and more say in household decisions. So along with being infected in greater numbers, women are also more affected by the HIV/AIDS pandemic than men. The majority of AIDS care happens at home, and women bear a disproportionate brunt of the responsibilities. In AIDS-affected households, women do all of the work. They care for sick husbands and family members. They cook, they clean, they shop, they wash. and they care for the family. It's called the care economy, and the time and energy and resources women spend on these tasks is unpaid and taken for granted. And they do all of this often while battling AIDS-related illnesses themselves. In fact, this was mentioned earlier, it's often girls who are forced to drop out of school and take care of their sick and dying parents. And yet, it's common sense that not only is an education crucial to a child's future, but school is also the place where most young people will learn about HIV/AIDS and how to protect themselves. This slide shows that the longer girls stay in school, the greater their knowledge of AIDS. It's not surprising. But by denying girls in particular the right to go to school or the ability to go to school, by forcing them to drop out to take care of family members, it's as if we're entrenching their fate. We're not letting them go to the place which will provide them the knowledge to protect themselves. We know that when girls are educated, they marry later, they have fewer children, their economic productivity grows, infant mortality is decreased, deaths in childbirth fall, general nutrition is improved. We have all sorts of development indicators that improve when girls and women stay in school. Part of the care economy, the work that's shouldered by women, includes caring for children who've lost their parents due to AIDS. Very quickly, to talk about orphans for a minute, more than 15 million children worldwide have lost one or both parents to HIV, and in Africa, the majority of orphans are in Africa. That's 12 million of them. It's a crisis of mammoth proportions, as you can imagine, 12 million children who've lost one or both parents. And I've spent the last 5 years traveling around southern and eastern Africa, visiting governments and associations of people living with AIDS, and I have yet to meet one government minister or officials working in government who have a real handle on how to deal with the orphans problem. Everyone is incredibly concerned, but there just isn't a great plan or sense of how to respond. Very few countries have social security nets to respond to the vulnerable in society, and fewer than 10% of children who are orphaned because of AIDS are receiving any kind of external support. In fact, what's happening is that children are being taken in by extended family members, but more often than not, they're being taken in by their grandmothers. It's grandmothers who across the continent first care for their sick and dying children, watch them die and bury them, and then they take in their bereaved grandchildren and begin the process of parenting all over again. Women who should be in the last years of their life are instead, their last years of life and should be sitting back and relaxing and being taken care of, are instead taking in 5, 6, 10 orphan grandchildren. There's very little data documenting this, but you only have to visit a village or a township to see that it really is the grandmothers who are shouldering this burden. They have little income, as I said. There are very few social security nets to support them, and they do what they can to plant and plow and grow a bit of food and sell vegetables in the market so that they can provide for their children. In order to effectively meet the needs of women in light of HIV/AIDS, I think that we need to look very closely at our strategies and our responses to the pandemic. The most common strategy that's been implemented has been the ABC strategy, which is to abstain, be faithful, and consistent use of condoms. It's worked pretty well in some places, and particularly in Uganda, but I think we need to acknowledge the fact that it doesn't work for everyone, and in particular, it's difficult for women, especially married women. If you're married, you don't want to abstain. Married women usually are being faithful or think they're in a faithful relationship, and it's not necessarily possible or even desirable to use a condom if you're married. So for a woman who believes she's in a monogamous relationship, the strategy that international institutions and agencies are using has no meaning for her and has no relevance in terms of protecting her. I think we need to look closely at the kinds of programs we're implementing, particularly with the lens of gender issues. I think we need to expand the ABCs. We could go all the way through the alphabet, and all the letters could stand for different things. But only when we have a more comprehensive response and strategy are we going to get to the root causes. I'm going to quickly just touch on microbicides and vaccines. I know they've been discussed in some of the other presentations. Just to say that when particularly looking at the impact of AIDS on women and gender issues, one of the most promising things coming up in the pipeline is microbicides, I think. It's, for those of you who don't know, a microbicide is a substance, a product, a gel or a cream that's applied vaginally, either topically or possibly an intravaginal ring that dispenses an active ingredient which would kill the virus and protect the woman from HIV infection. Some of the most exciting areas of development in microbicide research, I think, are around products that would kill the virus but allow for conception. So you can see how that would truly put sexual control back into the hands of women. A partially effective microbicide, one that's only 60% effective, could still prevent 2.5 million new HIV infections over a 3-year span. So research and development into this area is quite exciting, I think, and many believe that an effective microbicide is 5 to 7 years away. Just very quickly on a vaccine, a lot of these issues have been touched upon, but I really see vaccines as a gender issue when you consider that many believe that it's only a vaccine that'll bring an end to the epidemic, and that historically it's been vaccines that have eradicated disease. In terms of vaccines and microbicides, we have to, of course, keep in mind issues of accessibility, affordability, acceptability. Will women in a township use a gel that comes in a plastic tube and is in a cardboard box and needs to be disposed of somewhere? And we need to think all of those things through beforehand. We need to think about intellectual property issues so that once we have an effective product, it can get out as quickly and be distributed to as many women as possible at the cheapest price possible. So in the process of wrapping up, just to say that I think I've very quickly set out some of the issues in terms of gender inequality and the impact of AIDS on women, and they can feel quite overwhelming. It's a pretty pervasive, all-encompassing problem, and I think because it's so pervasive, we need solutions that are also just as kind of big and all-encompassing. One possible solution has been the call for a proper, well-funded UN agency for women. A number of high-profile people and organizations have been lobbying a UN panel that's been looking at UN reform to try and create a full-fledged agency for women. I think HIV/AIDS is just one example of how gender inequality can be deadly. There are lots of other diseases and lots of other problems faced by women. So we need a response that's holistic and comprehensive. We need better solutions for women. We need governments to do more. We need stronger leadership. And we need the UN, which has such an amazing and strong presence, particularly in Africa, to do a lot more than it's been doing. People like President Ellen Johnson Sirleaf and Graça Machel and others have publicly called that this UN agency for women, that it start with an initial budget of $1 billion US, which sounds like a lot of money, but UNICEF has a budget of over $2 billion, and when you consider that this UN agency would be meeting the needs of half the world's population, $1 billion doesn't start to sound like very much. That the agency should have technical expertise at headquarters, but also the capacity to be operational on the ground and work closely with government partners in country, and to have a high-level recognized leader at the same level of leadership as the other UN agencies. One of the things we can discuss the UN agency in the question and answer period. I won't give away how I really feel about it yet. But one of the things that I think a fully funded UN agency could do is to help address many of the invisible issues related to HIV/AIDS in women and related to women's rights issues. So sexual and reproductive health, which is often too controversial to get funding, but there are obviously very clear intersections between sexual and reproductive health and HIV/AIDS. Disability and HIV/AIDS, which isn't talked about very much. There's very little data on the issue, but there's lots of anecdotal evidence that disabled women are at greater risk of contracting HIV/AIDS, and that disabled women who are HIV positive have a really hard time being able to access treatment and care. And the issue of violence against women, which is starting to get more attention, but it really took the efforts of grassroots women's organizations and the women's movement to push it out of the private sphere and into the public limelight. And we need to continue the discussion looking at HIV, violence against women and HIV/AIDS and how the two are related. I think we also need to look at what's working on the ground. You know, there are lots of gaps we can point to, but we can also, if you spend any time on the continent, you can see that there are lots of projects and programs that are working, that are reaching people living with AIDS, that are reaching women, you know, in the most remote parts of regions. But they're often small scale and they're always underfunded. So we need to identify those programs and projects, and we need to fund them and support them. And I also think that we need to look very closely at our priorities. It's women and girls and children, which you'll hear about from Mark Klein, who are often at the bottom of the priority list. We need to look at that closely, and that needs to change. And I think we also need to understand that gender inequality really does fuel the spread of the epidemic, and not just recognize it, but do something about it. Without sustained interventions, without really strong leadership at the highest levels, and I don't just mean a little group of first ladies who talk about gender issues from time to time. I'm talking about elected officials who are really committed to protecting and promoting the rights of women in Africa and among donor countries who support those kind of interventions. We need really strong leadership, because I think without it, we're looking at pretty disastrous outcomes. We're looking at possible economic collapse. We're looking at small countries possibly becoming unstable and falling apart, and most importantly, we're looking at the loss of millions of lives. Thank you.
I was a bit intrigued about the gender differences in HIV prevalence rates in Kenya, because, you know, I mean, it is true that sexually transmitted infections increase the chances of HIV transmission, but I've never seen such dramatic differences. So I'm not sure where you got those data from. The other thing is that, you know, it is important to qualify that if you have a vaccine which may offer something like 30% protection, it could be actually counterproductive, because who are the people who are going to take it? Those who are going to indulge in risky sex behavior, and so, you know, you might actually have a perverse effect there. So I think that's not a particularly strong you know, policy option. The last thing I wanted to just make the point is that, you know, the time profile of infection between men and women, it has been fairly steady, and recently there may be some World Bank studies which are showing that's actually about similar. But I think one should be cautious about that as well, because that may have something to do with measurement issues within demographic and health surveys, where you really can't identify who the woman is married to in the household. So I think that these are some of these issues which may contaminate some of the data that you're actually presenting.
Well, I think the data is pretty clear, actually, and almost all of this data is from UNAIDS and WHO and from global epidemic reports. I mean, the information in Kenya is around 15 to 24-year-olds, and I think.
Oh, you're looking only between 15 and...
When I did between 10 and 45. Right, but if you look, in every single country in sub-Saharan Africa, more women than men are infected. And of course, there are variations. I mean, in some countries with low prevalence rates, it's 52% women, 48% men. But when you look more closely at young women, and when you look in Southern Africa, the gap is a lot greater, and it is disproportionately, the infections are disproportionately infecting women. And that, I mean, I think that's, you know, it's what UNAIDS and WHO say, and I think it's what the World Bank says, unless there's some very, very new data that came out in the last, you know, week. And I take your point about vaccines. I mean, I think that it's important to remember, a combination of responses, that even if we did have an effective vaccine that, let's say, was 60% effective, I think we still need to look at PMTCT, prevention of mother-to-child transmission, and we need to look at circumcision, and we need to look at microbicides. I mean, I think you're absolutely right that it's not going to be, there's not a magic solution out there, and that, and I think part of that is, as you say, who's going to get the vaccine, so we need to continue the kinds of multifaceted responses.
What would the budget for your new agency be?
No, I think $1 billion. I think $1 billion is a good place to start.
I think if UNICEF is getting 2, you should ask for 4.
Yeah.
Yeah.
I think you're right. Yeah. Which government do you think is going to come forward with the $4 billion?
What happened with the vote? I saw Steve Lewis over Christmas, and he said this would come for a vote in February, and he had a $2 billion budget on it at this. What's happened to the vote? Because it would have been in February.
The new Secretary General of the United Nations has come out in support of this recommendation to create a full-fledged amalgamated UN, amalgamating the existing small gender structures in the UN into one full agency. It has to go to the General Assembly. There are actually discussions, informal discussions this week among member states, the General Assembly, and it's not entirely clear what the timeline is. They may come to some agreement within the next couple of weeks, or it may have to be reopened at the General Assembly in September. The question is around funding and who will provide the funding, and the funding needs to come from member states, and looking at some of the detailed issues around who should be heading it. I actually think it could do wonders if there was operational capacity on the ground. I think some concerns people have are around the effectiveness of the UN generally. And, I think the UN has a lot of potential and could do amazing things. And I think we've all seen sort of moments of that, but whether they can really take this on and respond comprehensively and respond on the ground in the way that we'd like to see them, I think is a different kind of question, which is part of a bigger question about UN reform, which is taking place right now.
I'm worried about the data you produce. How were they collected? In our setting, and I've also discovered in many other countries, we have more women than men. Mm-hmm. But when you try to ask them intimate questions, these women are orphans. They've lost their husband, probably from HIV. So when you look into real-life situation, there are more women than men. Mm-hmm. But the men are dead. Mm-hmm. And we also suspect that we might have a second wave of epidemic. Their husbands are HIV negative, and those men are likely to be infected because of some of the factors we mentioned. The women will not disclose their status. So I think there's a problem there. My other question is, can we salvage the situation by applying the basic public health rule of case diagnosis, treatment, and contact tracing? Why are we treating HIV as if it's a different disease?
The data is from UNAIDS and WHO prevalence studies, so it's not, they're not actual numbers, they're prevalence rates, which are percentages. And you're right, we're getting a lot of new information as time goes on. So, 3-4 years ago, we were relying primarily on data from antenatal clinics. And more countries are including HIV/AIDS in their DHS surveys and doing more household studies. So in a country like Kenya, when we had antenatal surveys, the prevalence was around 16 to 18%, and when they did a DHS, we saw that it was actually 9%. So the collection of data and the epidemiology is getting better and better as time goes on. But all of this data is from UNAIDS and WHO, which works closely with ministries of health on the ground to collect the data, and it's part of their annual surveillance of, information on various diseases, and HIV/AIDS is one of them. So I agree with you in terms of demographics and, a population graph, more women than men, more young people than old people in most countries, but these are percentages that are taken from other antenatal studies or antenatal clinic studies or from DHS studies.
Why are we not adopting the standard public health approach of
I think it's, yeah.
Diagnosis, treatment, and contact tracing.
I think it's a really good question. I think, one of the things, and I think the way you've put it is one of the reasons that a lot of countries are looking at routine testing programs. So one of the problems is that the majority of people who are HIV positive don't know their status, so they actually can't go for treatment because they don't know they're HIV positive. So a number of countries, Botswana led the way by implementing a routine testing program. So if you went to a hospital and you were sick with something else, the doctor would say, I'm going to also recommend that when you go for blood work, you also get an HIV test, because HIV might be one of the things that's making you sick, and if only when we know that can we treat you for it. There have been some discussions around, if you implement routine testing, you also need to make sure you can offer the treatment and care. There was lots of discussion about people finding out what their status is, and then no health system, and then not having the infrastructure or health system to respond to it. But now, as treatment is being rolled out, as we're looking at strengthening health services, and we're getting the drugs out, and rollout is happening, and we have mechanisms like the Global Fund to fund treatment. I think you're right. We need a more proactive response to testing and treatment.
Contact tracing.
Meaning
The partners.
The
that are at
partners
risk.
tracing.
disclosure.
No, tracing the partners of the HIV-infected individual.
Right now, disclosing your status is a personal decision and a personal choice, and particularly for women, it's often fraught with complications, because often women disclose their status to their partners, to their husbands or boyfriends, and they get beaten up or kicked out of the house, or they face some sort of retribution. So disclosure, I think, is really important. I think we also need to acknowledge that we need some sort of support and referral system in place to support particularly women when it comes to disclosing their status. I've seen amazing programs. There's one I can think of in Lusaka where a counselor at a PMTCT clinic at the hospital actually goes home with the woman and helps her to disclose to her partner, so the woman has some support. This counselor, I've seen her write letters on behalf of the woman to the woman's husband to help, mediate and explain. And in many cases, that's worked well. And I think also when husbands and partners know that treatment is available, that it's to your benefit to be tested now and find out early what your status is so that you can be treated for it. I think that goes a long way as well to bringing people on side. But, I don't know if Mark Klein's going to talk about this, but it's very difficult. Prevention of mother-to-child transmission, testing women, there's an entry point for testing women because more women use healthcare facilities in Africa than men, and also that we've got an entry point when pregnant women come to clinics or healthcare centers to test them. Getting their partners on board to come to the clinic, even just to come to the clinic, let alone test, is a really difficult thing. And it's not just around HIV/AIDS, but it's around a whole host of healthcare interventions. So it requires a lot of work and effort, and I think it's work and effort that's well worth it. That should be that we should be supporting and we should be looking into. But it's a very difficult thing to get men to come along with their wives and partners, even when they know that it's for their health. It's gonna prove to be good for them to go to the clinic and be tested for whatever is possibly making them sick.
We have time for one more question, and I'm going to ask it if I can. It was a really fabulous and inspirational talk, and we have a lot of students in the audience who I think care very much about these issues, but the problem seems so enormous. Do you have specific suggestions for students who would like to become more involved?
Now, be careful, because she's recruiting you. And she gives you a lot of work to do. Work with her.
I think there's lots that students can do, and I think particularly if you're a student with background in public health or nursing or going to med school. I think there are often lots of opportunities to actually go to Africa or go to a developing country, and I think first to witness, to see firsthand what's happening, but then also hopefully possibly put some of your skills to use. I think it's good to be realistic when you go as a student to a developing country, that you may not, maybe to go as an American student to a developing country, you may not always be embraced with open arms, and I think that's okay. You're there to learn and you're there to help. But I think, as you heard this morning, for a lot of people who've been involved in international and global health issues for decades, it all started when they were, a teenager or in their 20s and had their first experience and fell in love with Bangladesh or fell in love with Africa or fell in love with the idea of doing work, doing public health work, doing some sort of public health service. So I think there are probably lots of opportunities through your school or through your community. I also feel that just issues of gender inequality, it's not even like we've really won the battle in North America. There's the glass ceiling for women, and there's gender inequality that permeates everybody's life, regardless of whether you live in Norway or Swaziland. It's a lot better in Norway, but I think the struggle continues. So I really feel like one of the first things you can do is to really educate yourself and be aware of what's going on, and to educate others. It's amazing. I've been doing this for 5 years, and I lived in South Africa for many years, and I'll be asked to give a talk or to talk to a group of students about what's happening, and I'll sort of say, oh yeah, more women than men are infected, and kind of skim through a bunch of things and try to get to the solutions, and you suddenly realize that actually a lot of people don't even know that. So I think the first place to start is to really just start informing yourselves and get an understanding of what's happening, so that you can see where you might be able to contribute and play a role.
We're going to move on to our next presentation, which will be given by Dr. Mark Klein, who is a professor of pediatrics and chief of retrovirology at the Baylor College of Medicine and Texas Children's Hospital. Dr. Klein is president of the Baylor International Pediatric AIDS Initiative, which provides HIV/AIDS treatment to more children than any other organization worldwide. And he's also the founder of the Pediatric AIDS Corps, which will send more than 250 doctors to Africa over 5 years, both to treat children with AIDS and to train local medical professionals about this disease. Dr. Klein.
Thank you very much. I'm very happy to be here. I'm appreciative of the opportunity. I had to leave during the middle part of the day. That's the hazard of having an office just across the way from Rice University. But I really do want to congratulate Rebecca and Rice for this program. I think it's been fantastic. I thoroughly enjoyed Dr. Glass's presentation this morning. I thought it set the stage beautifully for the conference, and Anurita Bain's presentation was just phenomenal. And I think we should start a movement to draft her to be the head of the first UN agency for women. Be a fabulous spokesperson for women around the world. I'm going to share with you sort of a personal story today. I had an organization at Baylor that is active in implementing programs for children and families with HIV around the world, and so I want to share with you kind of my own journey into global health and tell you a little bit about how the program has grown and diversified over time and where we're headed, I hope, in the next few years ahead. Now, how do I do this exactly? Aha. Okay. It's hiding from me. First, just to set the stage, let me tell you a little bit about the pediatric epidemic globally. About 2.3 million children worldwide were living with HIV/AIDS at the end of 2006. It was estimated that a little over 500,000 children were newly infected with the virus, almost all of them from mother-to-child transmission. 380,000 children died from HIV/AIDS in 2006 alone. That's the death of a child every minute of every hour, 24 hours a day, 365 days of the year. Sadly, only about 15% of HIV-infected children worldwide currently have access to treatment. So the drugs that really have transformed HIV for children in the United States have not had a great impact on HIV-infected children in the poor countries of the world. So anyone who has worked in any hospital in sub-Saharan Africa over the past decade will recognize the image of a stunted, wasted infant or toddler dying with AIDS, often with chronic diarrhea or pneumonia or tuberculosis. 60 to 70% of all admissions to hospitals in sub-Saharan Africa, to pediatric wards, and deaths are attributed to HIV/AIDS today. Globally, UNICEF recently has estimated that about 4% of all under age 5 deaths can be attributed to HIV/AIDS, but you can see the figures here for some of the countries in southern Africa. In Botswana in particular, it's estimated that 57.7% of all child deaths can be attributed to HIV/AIDS. That means HIV is killing more children than all other causes combined. This is becoming a dominant cause of mortality in sub-Saharan Africa. Stephen Lewis, Anurita's boss, said in January of 2005, in the instance of antiretroviral therapy, the scenario for children is quite simply doomsday. But why should this be the case? More than a decade after the advent of highly active antiretroviral therapy for HIV-infected children in the United States, where children who literally were on their deathbeds were restored to health. Many of those children are alive and perfectly healthy today. Why should children in the poor countries still be waiting for their opportunity to take these life-saving medications? Well, certainly there are a number of barriers that exist to the treatment of children. There has been a lack of infrastructure. The clinics for administering the therapy have not existed. The laboratories for monitoring the therapy appropriately have not existed. There has been a lack and loss of human capacity. We know that the productive capacity of African professional schools is very low, so the number of doctors and nurses and pharmacists and social workers that are being produced is relatively small. And then in addition, there is an exodus of professionals from the region, professionals leaving the developing world to work in the developed world. And then there are deaths of professionals, many of them as a consequence of HIV/AIDS across the region. Expense certainly has been an issue. Now the cost of the medications has come way down, but when you're dealing with very poor countries with per capita expenditures for health in the neighborhood of $30 to $50 per year, the drugs still are prohibitively expensive. There has been a lack of commitment to the treatment of children. In very many settings, priority has been given to adults. When an HIV-infected child is restored to health, he or she does not go back to work, they don't pay taxes, they don't vote. And so some governments have said we should give priority to the adults. One minister of health actually said to me, look, if we treat the adults, they can make more children and replace the children who die from AIDS. And then there's the perceived complexity of pediatric treatment. As health professionals, we've done a poor job of communicating to our counterparts the fact that children are not more complex. They are not more difficult to treat. The drugs can be given safely, they can be dosed appropriately, and children can derive the same benefits that adults do from treatment for HIV. So it was really in this context that the Baylor International Pediatric AIDS Initiative was established in 1996. The initiative is committed to improving the health and lives of HIV-infected children and families globally, and is currently active in Romania, where it began, in Mexico, in China, and more than 20 countries in Africa. Now, Romania may seem like a very strange place to start a global pediatric AIDS program, but this was an outgrowth of a trip that I made to Romania in February of 1996. I had been taking care of HIV-infected children in the United States for a decade at that time, and I thought I knew everything there was to know about children and HIV. I thought I'd seen it all. But when I first set foot in Romania, I was floored by the sight of hundreds of little walking skeletons, stunted, wasted children with open sores on the skin, lesions in their mouths, dying with HIV wasting and various opportunistic infections. And I flew home knowing that my life had changed forever, that I could not go back to doing what I had been doing before. And I met with my boss, Dr. Feigen, at Texas Children's Hospital, and I asked him for permission to develop an international pediatric AIDS program, and all of the rest has been an outgrowth of that. When we began working in Romania in 1996, we gravitated to this place. This is the Constanța Municipal Hospital. Constanța is a port city in the eastern part of Romania on the Black Sea. And this old institution in Constanța has cared for more HIV-infected children than any other institution in Europe. In the late 1990s, when we began working in Constanza, I met children like George. He was 11 years old when the photograph was taken. He weighed 40 pounds. He was the size of an average 4-year-old. And this is Alina, who was 10 years old. 2 of several hundred children in care at that time at the municipal hospital in Constanza who lived with AIDS and died of AIDS without ever having an opportunity to take an antiretroviral medication. When we began working in Romania, we started out very simply. We didn't have a lot of money, and so we said, what can we do that will have an impact on the health of the children, can be done relatively inexpensively? We began cataloging the health problems. I wanted to have hard data as to what kinds of issues the children had. Were they suffering from tuberculosis or chronic diarrhea and malnutrition? What were the problems they were actually having? And so we developed a computerized database, actually with support from the Fogarty International Center, and we began collecting information on the children. We provided nutritional supplements. We treated their tuberculosis. We treated their diarrheal disease. We gave them trimethoprim sulfamethoxazole to prevent a serious type of pneumonia that people with HIV/AIDS suffer. This was the clinic in the early days. It was a single room, and the white-haired lady on the far left of the slide is Dr. Matusha, who was the director of the pediatric AIDS program in Constanza at that time. We began working with the nursing staff at the hospital, doing simple things like teaching the nurses how to wash their hands effectively. There was a lot of cross-infection that was occurring in the institution, and we said, well, maybe we could teach hand washing and cut down on rates of cross-infection. And so this is one of our nurses from Texas Children's Hospital doing a hand-washing demonstration for one of the Romanian nurses. And we began to see modest improvements in the children's health. But we knew that we wanted to establish a program of antiretroviral therapy. We wanted to transform the health of children with HIV. We knew that that would not be possible at the municipal hospital. The proper controls weren't in place. There wasn't even a facility for locked storage of medications. And so I began looking for a building, and I traveled around Constanza with a real estate agent. Romanian real estate agents are just like American real estate agents. They drive nice cars, they dress very well, and I'd looked at a few buildings without any success. And I was in clinic with Dr. Matusha one day, and she said to me, oh, you know, the hospital director mentioned to me that there's an old building the hospital owns that's only about 3 kilometers from here, and they're just going to tear it down if you don't want it. But he says if you'd like to have it, you can have it for your pediatric AIDS center. So I said, let's go take a look at it. So I shot this photograph the first time I ever saw the building in March of 2000. And as I've said in other venues, in Texas nomenclature, this would be a unique fixer-upper opportunity. The building was in a sad state of disrepair, as you can see. There were actually squatters living in the building. There was human excrement all over the floors, the walls. All of the plumbing fixtures were gone. And I looked at it and I thought there was no way this would ever be a pediatric AIDS center. But we had an excellent engineer working with us from Washington, D.C. He'd come to Romania to look at a couple of other buildings for me. And I called him and I asked him to come over and take a look. He poured through it for 2 days. And when he was done, he said something very memorable. He said, you know, it has a few cosmetic problems. And that's what engineering expertise will buy you. But I'm joking a little. But no, the memorable part was he said that structurally it's very sound. It'll be here 100 years from now. And with that, we decided we would try to renovate this building. There was a little problem, and that was it was going to cost about $500,000, which we didn't have. But just at that time, the Houston Chronicle published an article called Worlds Apart that contrasted the advances that had been made in pediatric HIV/AIDS care and treatment in the United States with what was happening in the developing world. And the reporter and the photographer had traveled to Romania with me. Most of the photographs you see today were shot by the photographer Smiley Poole. It was a big feature story in the Sunday Houston Chronicle. The very next day, on Monday morning, I was in my office at Texas Children's, and I got a call from a woman, and she said, my name is Sister Olive, and I'm the CEO of the Sisters of Charity of the Incarnate Word. And she said, you know, we were having our annual Board of Directors meeting over the weekend. The Pope has declared a Jubilee year. He has asked all of the congregations to look over their mission statements to see if they should be changed or expanded in some way. And on Saturday, we spent a long time talking about pediatric AIDS as a possible expansion of our mission, and then the Sunday newspaper arrived. And she said, we thought this was almost providential. And it says in the article that you want to start a program for treating children with HIV in Romania. How much is that going to cost? And I said, about $500,000. And she said, if I sent you a check for $400,000, would it help? And I said, yeah, that would help, about 80%. No, I wasn't sure that the call was even for real, but I was very nice to her, and I said yes, that would be very helpful. And at the end of the week, received a check for $400,000, and we were off and running. So I guess maybe lesson one is I was naive enough at the time not to know this, but Dr. Glass and other people who've been doing this for a very long time probably will attest that you can't always see your way clear to your ultimate goal, but if the idea has merit, somehow it seems to work out if you keep after it. And that was certainly the case, and the first example of many as we've developed this global program. So in a relatively short period of time, the old building became the Romanian American Children's Center, Centrul de Copii Romano-American. And this center has been open now since April 6th of 2001. So we just celebrated our 6th anniversary. It's a large outpatient clinic. This is actually the largest pediatric HIV treatment center in Europe today. There are over 600 children receiving treatment in the center. And I could show you reams of data, outcome data, decreased rates of hospitalization, decreased rates of opportunistic illnesses. We have lots and lots of data, but this is the only slide I'm going to show you, and I think it's the most compelling. This is the annual death rate for HIV-infected children in Constanza. Now, I told you we began to monitor this very carefully with this grant from the Fogarty Center in 1998. And you can see the center opened in April of 2001. The program of highly active antiretroviral therapy was initiated in November of 2001. And you can see what happened to the death rate. This is the difference between 109 child deaths in 2001 and 7 deaths in 2004. So when we say children are living instead of dying, we mean literally children are living instead of dying. They're living instead of dying. And the drugs work every bit as well in resource-poor settings as they do in the United States or Western Europe. This was an incredible experience, and once you've had the experience, you just want to do it over and over and over again. The place we wanted to replicate this was Africa for obvious reasons. We'd begun working in Botswana in 1999. At that time, Botswana had the worst epidemic in the world. So when we began to see the early data in Romania, I made an appointment to see the Minister of Health, Joy Pumapi, in Botswana. And I sat down with her and I showed her some of the early data, and I said, would you be willing to partner with us and develop a children's center here in Botswana to treat HIV-infected children? At the time, there was not a single child in Botswana receiving antiretroviral drugs. And she said she would partner. And with that, we sent some proposals out, and the Bristol Myers Squibb Foundation gave us a cash grant to build a children's center. We said, okay, we don't want children to die waiting for a building to be put up, so we wanted to start a transitional program. We recruited this gentleman, Gabriel Anabwani, who some of you may know. Gabriel is a Kenyan pediatrician. We recruited him, we brought him to Baylor College of Medicine under our Fogarty grant, and we trained him in HIV, and we sent him back to Botswana with a nurse that we also trained. And we put up a little sign. We said, this is the new Bana clinic. Bana is the Setswana word for children. And we said, if your child's been diagnosed with HIV, bring the child to us and we'll begin treating the children. And we're going to collect data so that we can see that the drugs are being taken safely and effectively and so forth. So with $25,000 literally of renovation at the Princess Marina Hospital in Gaborone, we opened the Bana clinic. This is what the waiting area looked like in the early days, with the mothers and fathers and their kids waiting to be seen. I'm not sure whose dog that is, but it's not mine, I know that. And we began seeing children. We put 200 children on antiretroviral treatment in about 6 months' time while we put up the big building. This is the way the building looked while it was under construction, and this is how it looks today. This is the Botswana Baylor Children's Clinical Center of Excellence. This was the first comprehensive pediatric HIV treatment center on the African continent. Now, there were a lot of naysayers around. This was in 2003, late 2002, early 2003, and there were a lot of experts who were saying, even if treatment is made available, people will not seek it out. because of the stigma, the discrimination that you've heard about. And in Botswana in particular, there was a media tour of the building the day before it opened. And a reporter went home to London and said that Baylor had built a great white elephant on the African savannah, that locals said no one will ever pass through the doors because of the stigma. Well, we were swamped with children and mothers the day we opened. The women, the mothers of Botswana spoke with their feet. They brought their children to the clinic to be tested. They brought their children for treatment. It really was a remarkable experience. And it was an illustration for me of the fact that treatment is a great destigmatizer. Stigma is not an enduring impediment to treatment because treatment destigmatizes the disease. And what has happened in Botswana? Exactly what happened in Romania. Here is the annual death rate. And again, I could show you lots and lots of other data, but I'll just stick to this. 2003 was the year the center opened in June. The death rate was 4.7%. It dropped last year to 0.3%. That represents 4 deaths out of more than 1,600 children in care in the center. And I would guess that no one in the room who is not a pediatric HIV specialist can imagine that with a population of children so large you would see so few deaths, because that's not the image the world has in its head of what an HIV-infected child should be experiencing. We, I think, assume that they live short, painful lives and they die at very young ages. But again, children can live instead of die if treatment is made available to them. So this center in Botswana really has claimed a lot of attention. I think this was an unexpected outcome. The fact that people would seek out treatment and the fact that children could benefit as well as they can from treatment was unexpected. And so late in 2003, when we saw that enrollment was occurring at a very high pace in Botswana, we said this is something now that we have to replicate in other places in Africa. And we brought together a number of experts from around the world, principally Africa, to Baylor and Texas Children's in January of 2004 to discuss the possibility of the creation of what we called a Children's Clinical Centers of Excellence network, a network of children's centers across Africa and around the world that would be committed to high quality, high impact, highly ethical pediatric and family HIV/AIDS care and treatment, health professional training, and clinical research, with the overarching goal being catalyzing pediatric HIV/AIDS care and treatment globally. In other words, the training and the research are in support of care and treatment objectives. And a decision was made to move forward on this. This network has grown dramatically in just 3 years. The stars represent sites of centers that now have been built and opened or are under construction. So in addition to the center in Constanza, Romania, and the center in Gaborone, Botswana that I've mentioned, we opened a center on World AIDS Day, December 1st, 2005 in Masera, Lesotho, on February 24th of 2006 in Babani, Swaziland, on November 2nd of last year in Lilongwe, Malawi. We've been working in Kampala, Uganda at the Malago Hospital since 2004, but we're building a large center on the Malago Hospital campus currently that will be open in September. And we broke ground in January in Bobo Dioulasso, Burkina Faso. This will be one of the first pediatric AIDS centers in West Africa. And then we're just very shortly going to announce another center in Kenya, in the Kisumu region of Western Kenya. In addition, we're working with a center in Benghazi, Libya, where there's a hospital-acquired outbreak of pediatric AIDS, and in the Yunnan province of southern China. So all of these centers now are operational in one form or another. Even those that are under construction, we followed exactly the same path we followed in Botswana. We've opened a transitional facility and begun to treat children in advance of opening the big center. And the centers collaborate with one another. They exchange best practices. They engage in training exchanges. This is really a powerful thing, I think, that has been developed and is developing. All of these centers are collaborative. All of them are operated under memorandums of agreement between Baylor College of Medicine, Texas Children's Hospital, and the host government. The government is always our principal partner. They're comprehensive. They are HIV/AIDS focused, but we provide primary care to children and families. And so we give immunizations, we treat ear infections, sore throats, and so forth. They're family-centered. The child is the point of entry to all of our centers, but we know that those children are attached to, very likely, to HIV-infected family members. Across Africa, In very many places, adults are being treated, but children have been abandoned therapeutically. In our centers, we have the potential to do this exactly in reverse, treat the child and abandon the adults and produce a generation of AIDS orphans. We can't afford to have that happen. So we either provide care and treatment directly to the mothers and fathers as well, or we affiliate with organizations that can provide care and treatment to the mothers and fathers so that we're sure to keep intact to the extent possible the family unit. The centers are all care and treatment focused, and they provide support for regional and national scale-up of programs of care and treatment through training. In the interest of time, I'm not going to show you very many pictures. This is the center in Lesotho. It sits high on a hill just southeast of the downtown area. When it was under construction, the rumor was that it was the new National Olympic Training Facility. I don't know that there was very much disappointment when it was discovered that it was actually a pediatric HIV center. But these are beautiful and very substantial facilities. Now, the demand for services in all of these places has been huge. This is a photograph that was taken on an average Tuesday morning in the small clinic at Malago Hospital in Kampala that we work out of. And you can see here the number of mothers and children that are waiting for care. And the number of professionals to deliver the care is minuscule by U.S. standards. So people like this gentleman, who is a Ugandan pediatrician who works in our clinic at Malago, are worth their weight in gold. In many of the settings in which we're working, you simply can't find pediatricians or doctors or nurses or pharmacists or anyone really to deliver the care that is necessary. If you try to put some numbers around this, if you look at data that was generated at the University of Michigan School of Public Health in 2004, you can see that there are 106 U.S. pediatricians for every 100,000 children less than 15 years of age. But look at the figures for some of these other countries. Now, I took data from the World Health Organization as to how many children there are in each of these countries under age 15, and I collected data from the Ministries of Health regarding how many registered pediatricians there were. So I derived these other numbers. But in Botswana, there are 2.5 pediatricians for every 100,000 children. Lesotho, 0.4. That represents, by the way, 1 pediatrician in the entire country of Lesotho. So if you put an army of trainers on the ground, you would not find the pediatric professionals to train. So our answer to this on an interim or emergency basis was the creation of the Pediatric AIDS Corps. We said, okay, we've looked for local professionals. We can't find them. What has become rate limiting for delivering care is the availability of professionals. So on an interim or emergency basis, we're going to recruit physicians, and we're going to send them to Africa to work on a long-term basis, 1 year, 2 years, 3 years each, to help scale up the care and treatment of HIV-infected children and families. The program just started last summer. This was the first class of the Pediatric AIDS Corps, 52 doctors, 40 of them pediatricians, some family doctors, some internists, that now are on the ground and working in 7 countries in Africa. And these are fantastic people. Their biographies look concocted or contrived. When you read them, you can't imagine that these people are for real. People like Keba Jobarte. His father was Gambian, but Keba was born in New York City. Grew up in New York. He's a graduate of Princeton University, Yale University Medical School, has a public health degree from Harvard, trained in pediatrics at Columbia. When I interviewed him over the telephone, I said to him, you know, I'd love to offer you a spot, but if you'd only trained at better institutions. He didn't know what to make of me. There was silence on the phone. He's working in the clinic in Malawi currently. This is Joanna Lionar. She's one of 3 Canadians in the group, and she's working in the clinic in Lesotho with a very tiny baby. She's a graduate of McMaster University and has a public health degree from Harvard. These are all just fantastic people, and the difference that they have made is just enormous. Here are the numbers. More than 13,000 children now in care in the centers that we operate in all of these poor countries, and over 6,000 children receiving highly active antiretroviral therapy. We still consider this a pilot program. This has got to be scaled up. You've heard some of the numbers today. UNICEF estimates that there are about 780,000 children currently in immediate need of antiretroviral treatment. So 6,000 may sound a little bit impressive when you first hear it, but in the context of nearly 800,000 children in immediate need of life-saving treatment, it's a drop in the bucket. We have to scale this number up rapidly or we will lose hundreds of thousands of children to this disease. And then at the same time that the physicians are providing care and treatment, they're training locals. And so on the bottom line here, you can see the number of local professionals that received some kind of training experience in the centers in the month of March of this year alone, over 1,100 individuals. Some of these are for just 1-hour sessions, and some of them are attachments to the clinics for longer periods of time. So what about research? Well, research, we believe, is going to be key, and we think that research can serve a couple of functions in the centers. We think that research will help inform the care and treatment of the children and families. We think that sponsored research will help to support the operations of the centers, to sustain the centers over time. But we have certain prerequisites for research in the network. The research must be of high impact and high quality. It has to be ethically unassailable. This is true for all research, I suppose, all human subjects research, but particularly in this case, we cannot put in jeopardy our care and treatment programs by doing any kind of research project that could be interpreted as unethical in any way, because now we're entrusted with the lives of thousands of children. The research must be locally relevant, and it must advance our care and treatment objectives. So there have been a number of research projects initiated, many of these by the young doctors that are part of the Pediatric AIDS Corps. I'm not going to read these off for you, but there are a number of projects going on in almost all of the settings now. So where do we go from here? Very clearly, we want to work more diligently on prevention of mother-to-child transmission of HIV. We have to squeeze down the pipeline, reduce the number of infants being born with HIV. Until we do that, we will not gain a foothold and really get on top of the pediatric HIV/AIDS epidemic, because we'll never be able to treat hundreds of thousands and millions of HIV-infected children. So we want to carefully integrate our care and treatment services with existing PMT-CT services or create our own PMT-CT services if necessary. We are going to move forcefully into hospital-based testing of children. All across Africa, as I said, children with HIV now account for the majority of admissions to pediatric wards. But in very few places are the children routinely being offered testing for HIV. We have to do that. We're developing satellite and outreach services. This is happening in every single one of our centers now, attachments to primary health centers in semi-urban and rural areas to spread the benefits of these centers to much broader geographic regions. And we're very serious about accountability and evaluation of outcomes. We're sort of on the leading edge of what I hope will be dozens or hundreds of institutions that are doing this kind of work in Africa and around the world. We need to carefully chronicle what we're doing right, and we need to tell people about what we could have done better so that we can inform the way forward for others. For too long, children have been on the outside looking in. Adults have to advocate for them. Life-saving HIV/AIDS care and treatment can be administered to large numbers of children in resource-poor settings with rates of success comparable to those observed in the U.S. I think we and many other groups now have documented this. American professionals and institutions can play important roles in immediately scaling up the care and treatment of hundreds of thousands of children with HIV/AIDS, and I would say other life-threatening diseases as well. HIV/AIDS can be a model for what can be done for other life-threatening diseases. We have the support of a number of organizations and institutions, including the Fogarty Center, the U.S. Centers for Disease Control, the Bristol Myers Squibb Foundation, the Abbott Fund, and UNICEF. Thank you very much.
Yeah. Oh, Mark, that's really an amazing story. Truly inspirational. My question is about the source of medications that you have. You work across so many countries. Clearly, you have supply issues. So how do you get medications?
Yannick, we get medications from a variety of sources. We have donated medicines in Romania. We dispense donated medicines from that clinic in Romania at a rate of about $400,000 a month. It's a big, big drug donation program. The donations are made by pharmaceutical companies to Baylor College of Medicine. We don't physically have them at Baylor, but they're shipped from the United States to Romania by AmeriCares, handles all of the customs and importation stuff, and end up in our clinic. We buy antiretrovirals in Uganda with PEPFAR money, U.S. government money. The same is true in Botswana. Many of the drugs in Botswana are provided through a national ARV program. We have drugs purchased through the Global Fund money in Lesotho and Swaziland and Burkina Faso. So the formula varies from place to place, but everywhere we've found a way to get our hands on medications in ample quantities, and nowhere is the availability of antiretrovirals rate limiting for us.
Mark, why did, and this has been a great program, but why didn't it start 5 years? What kept it from starting earlier than it has?
Well, there was no money to do this kind of thing. I think probably the nicest introduction I've ever had for any talk I've ever given was at the University of Maryland a year ago. And when the guy introduced me, he said, Mark Klein does this work with pediatric kids with pediatric HIV in really poor countries. And he started doing it before there was any money to do it. But there were no resources, really. I mean, when we got started, no, I don't think anyone thought that this was a realistic possibility. You could talk to experts who said, it'll be a decade or 20 years before treatment will be available, and certainly not the drugs we have available now. So people had to get a little bit of experience and some confidence that it could be done effectively, that drugs wouldn't be diverted, that there wouldn't be undue toxicity and so forth. So I think that's probably the short answer. Yes, sir.
I think part of the answer is also because we mentioned it. Children are relegated to the background in many of our cultures. There's also the belief that they are not likely to survive. So why invest in them? Mm-hmm. I think your success story is quite remarkable, and I want to congratulate you. My question is, why have you left Nigeria?
Yeah, there's some really good people working in Nigeria, and we've done a little bit of training in Nigeria, but there's as you probably know, the University of Maryland and Catholic Relief Services, they have a very large Track 1 PEPFAR grant. It's over a $100 million grant for work in Nigeria. And they have excellent pediatric professionals in that program. And so when we looked at sort of priority countries, we took a careful look at Nigeria, but decided that they were well covered with the resources the U.S. government was providing, the University of Maryland, Catholic Relief Services, and so we decided we would go other places where there were fewer people working already. Wendy?
Mark, it's amazing what you've done, but as you point out, it's a drop in the bucket relative to the amount of disease there is across Africa and other parts of the world. And the question I have is, how are you going to keep the stream of drugs up and ramp that drug supply up to address the large proportion of kids that need it now?
Yeah. The key, I think, for us, first of all, this model that we've come up with, these centers of excellence, they are primary health centers, but they're sort of a cut above what you would expect to see in a small village or something. So they're primary health centers that really are ideally suited to urban areas. So our model needs to grow by attaching itself and supporting primary health centers. And as I mentioned, that's happening everywhere now. So in Botswana, the government actually designated 19 primary health centers for scale-up of pediatric HIV care and treatment. And we help to staff those. We provide technical backup for the doctors and the nurses who are working in those centers. And I think we can do a lot of that and help give professionals the confidence that they need to get started. Once they get a little bit of their own experience, they're fine. But it's just taking that first step and having the confidence that it can be done safely that's difficult.
But do you think you can get the drugs?
The drugs, I think, are not going to be rate limiting, honestly. I don't think the drugs are rate limiting anywhere anymore. I think that this is a real misconception that's still out there. They were at one point in time. But I'll tell you, number one rate limiting factor right now is human capacity. And the second one, for infants in particular, is diagnostics. Because we do not have a reliable method of diagnosing infants. Now, dried blood spot, DNA PCR is being rolled out in a lot of places. But it's still going to be some time before that's widely available. Even where it is available, frequently it's shipped by DHL to South Africa. It takes a month to turn around. Getting an infant on early therapy is extremely difficult. So for infants, diagnostics is a very big issue. But I think that if we can, on an interim basis, put professionals on the ground where they're not local professionals to do the work, help to build the local capacity, hopefully build some infrastructure, provide the tools that will draw some professionals back to the region. We've had some success doing that in Lesotho and Swaziland and Malawi. I think we could go a long way towards getting much, much larger numbers of children into care and treatment.
What about formulation for younger children? This has always been an issue in the treatment of AIDS, and a difficult task to take some of these drugs because most of them have a very bitter taste.
Right. Yeah. So the question is about formulations. You know, liquids have a number of problems. One is, as you've heard, a lot of the families walk to and from clinic. And so carrying big bottles of medication is unwieldy, very difficult or impossible. Many of the liquid medicines require refrigeration, which is not practical in a lot of settings. And so you're left with these little pills that sometimes are scored and can be split, and sometimes they're not. When they are split, we're not sure that the children get a consistent dosage of medicine. In other words, is the drug evenly distributed within the pill?
It
So
may not matter, though.
So it is.
Taking it is probably better than not taking it.
Well, I don't know. Taking enough is better than not taking, but taking half of enough is, maybe worse than not taking it at all because of resistance development. But anyway, so there are all these problems. But I think for the children over 3, we've tried to be a little bit creative, teaching even very young children to swallow pills. And most of these drugs have a pretty good therapeutic index, so you can overdose a little and probably not incur very much in the way of toxicity. So over age 3, I have a fair degree of confidence that we can do this pretty well. Under 3, it's still problematic because the availability of liquid formulations is sort of hit or miss.
Yeah, I think the industry should perhaps come together. It's maybe something you might want to think about to bring the expertise about pharmaceutics.
Yeah.
Because these are very difficult.
They're very difficult.
They're very difficult drugs to deal with. But we could bring a lot of brains from academia and other to work on it. I think would be a big plus.
I was meeting with a medicinal chemist from Roche Laboratories a while back who said that the protease inhibitors, the HIV protease inhibitors, were bar none the single most difficult class of drugs he'd ever worked with in his entire career. There is an initiative on this right now. About a year and a half ago, the First Lady announced a public-private partnership initiative. PEPFAR is involved, and the major pharmaceutical companies that are involved with antiretroviral drug development are all involved, and a few organizations like BPI. And there is a formulations subcommittee of that public-private partnership that is working on exactly this. And there was a meeting just in February in Washington on the subject.
What about rectal administration? I know kids hate it. But let's face it, It's a good absorber.
Yeah, day in, day out for years. Yeah. I think it'd be a tough sell. Just like injectable medications are going to be, by definition, a very, very tough sell.
So I don't know. I'm a cancer doctor, and when people think they have to do something to live, they often get it like that. And so if you can't make a liquid that works, a suppository.
People have talked about transcutaneous administration medications, and so there are a lot of ideas out there. Yes.
I just wanted to ask, these children who come to the clinics, they are accompanied by their mother or father or somebody. Do you educate the mothers also, because they may transmit the thing to future children that they may have?
We do. We provide education at every visit. We've developed written materials, videotape materials. In most of the waiting rooms now, we have television set up so that they get little educational programs while they wait to see the doctor, so that they're not wasting time in the clinic. So yeah, we think the care and treatment services and education go hand in hand.
Maybe one more. Mark, I think the innovation in pediatric formulation, in my mind, is probably not going to come much from the developed world. As we have cut down on the transmission, there is just not a big market. I haven't seen new liquid formulations being marketed in this country for quite a while now. And, no drug company really knocks my door anymore, because we are not creating infected kids anymore. So I think the innovation is going to come from developing world. And if you look at the Indian manufacturers, they have made combination liquid preparations, things that we don't even have one example of in this country. So I think working with manufacturers in the developing world is going to be the key.
Yeah.
It's not going to be from manufacturers here.
Yeah, and I should have said it, this public-private partnership initiative that PEPFAR is sponsoring includes generic manufacturers from Cipla in India and from a couple of other companies. And so they're part of that process too. There's been kind of a catch-22 situation that's existed when you stop to think about it. The number of children on treatment, on antiretroviral treatment, has been very, very small. So there have not been market forces that have driven the development of pediatric formulations. And because they're not pediatric formulations, children haven't been put on treatment. So it's a circular sort of situation that arises. We have to get more, as we get more and more children on treatment, there will be more reward for the companies that have suitable pediatric formulations.
Thank you very much. We have a couple of changes in our schedule because we're running a little bit behind today. Dr. Fallon will present her talk as part of the talks tomorrow. Another change that we have in our schedule is that originally we had invited the Minister of Health of Nigeria, Dr. Lambo, to come and join us to speak about achieving the Health Millennium Development Goals and the role that biotechnology innovations could play in achieving those goals. Unfortunately, because of the ongoing presidential elections and state elections in Nigeria, Dr. Lambo was unable to join us. However, we're very fortunate that Isaac Adewale is here in his place to present the talk. Professor Adewale is a professor of obstetrics and gynecology at the University of Ibadan College of Medicine in Nigeria. He has served in a number of important administrative roles, first as a department head in obstetrics and gynecology, then as dean of the Faculty of Clinical Sciences and Dentistry, and then as provost of the medical school. He's currently a co-PI on the Harvard PEPFAR HIV/AIDS Care and Treatment Program at University College Hospital, which has over 30,000 Nigerian women and men under treatment, care, and support. So I'm pleased to welcome Dr. Adewale.
Thank you very much, Rebecca. It's a pleasure being here, and I want to thank you for inviting me, as well as inviting the Honorable Minister. He loved to be here, and in fact, he accepted to be at this meeting. Unfortunately, at a cabinet meeting about 2 weeks ago, the President told him that none of the ministers should travel out of the country. And in fact, he was unable to attend the African Health Ministers meeting in Johannesburg last week. So I really apologize on his behalf. But he sent his talk, and I'm going to present on his behalf. I've also tried to dress like him, so... And this is probably the second time in a couple of months that I've had cause to represent him at an international engagement, and on both occasions I've dressed like him. The title of his presentation is Achieving the Health Millennium Development Goals in the Developing World, the Expected Innovative Biotechnology Solutions. He has dedicated this presentation to all our friends, female, male, white, black, Latino, Asian, Native American, old, young, and those who believe in us. And he has also included that beautiful capture, Who Cares for the Health of Africans? And this is dedicated to all those who care for the health of Africans, including people like Mark. And I thank you for your nice work in many of the African countries. I've actually visited your center in Botswana. It's an excellent facility. And 2 of the pediatricians there are Nigerians, and they train in Nigeria, and they're doing well. That's Nigeria, located in Africa. The map of Africa actually can be likened to a pistol, and Nigeria stands really at the trigger point. And that represents the importance of Africa, of Nigeria to the African situation. Like other developing countries, Nigeria is locked in the twin pandemics of infectious and non-communicable diseases, and the list is quite a legion: malaria, tuberculosis, infective gastroenteritis, pneumonia, AIDS, and the non-communicable diseases like trauma, cancer, heart diseases, diabetes mellitus, and hypertension. The Millennium Development Goal was adopted by 189 nations and signed by 147 heads of state and governments during the UN Millennium Summit in September 2000. And according to the then Secretary General of the UN, it was to be a blueprint for building a better world in the 21st century. We're quite aware that there are quite a number of development agendas, right from the first population conference in Mexico in 1974. Thereafter, there have been many population meetings on development. And the attempt by world leaders was actually to commit governments, particularly in developing countries, to develop the health sector and many other sectors of the economy in many of these countries. The Millennium Development Goals actually comprise of 8 broad goals. The first one is to eradicate extreme poverty and hunger, to achieve universal primary education, to promote gender equality and empower women, reduce child mortality, improve maternal health, combat HIV/AIDS, malaria, and other diseases, and ensure environmental sustainability and develop a global partnership for development. 3 of them, the goal 4, 5, and 6, are health-related. And the minister's talk is actually to see how we can use biotechnology to attain these health-related goals. That's quite a busy slide, but what I've done is actually to lift it out. One, we have the Millennium Development Goals, as well as the midterm agenda with reference to Africa, Asia, Oceania, Latin America, and the Caribbean. And the next presentation tries to bring out the situation. We try to divide it into 2 columns. The first column deals with the situation in North Africa, and then the second column deals with the situation in Sub-Saharan Africa. When we look at child mortality, whereas efforts are on track to reduce mortality in under 5-year-old in northern African countries, there has been no change in Sub-Saharan Africa. In fact, the values are very high. When it comes to measles immunization, the target is to achieve 85% of population by 2015. In the North African countries, they've been able to meet this target. In many of the countries in Sub-Saharan Africa, this target has not been met. When we talk about maternal health, the goal is to reduce maternal death by 75% by year 2015. The countries in the North African area, they've achieved a moderate reduction. The levels are quite low. But in many of the Sub-Saharan African countries, we are dealing with very high maternal mortality ratios. What about HIV/AIDS, malaria, and others? This situation is the same. We've made only modest reduction in HIV pandemic, and as we've been told by many of the speakers, Sub-Saharan Africa, with 10% of the world population, still account for about 60 to 65% of the global HIV/AIDS burden. What about malaria? It's still a major problem. We talked about the ACT combinations today. The truth of the matter is that many of the ACT combinations are beyond the reach of many of the Africans. Even on the market, many of the ACT combinations will cost quite about $10, $15 US, and that's beyond what many people can afford. TB is a major problem. It is being driven by the HIV pandemic, and many of our people die from tuberculosis. There is actually some misplacement. I was trying to locate this slide. I wonder what happened during. This is actually an introduction to Nigeria to give you an idea as to what Nigeria is like. The size is about the size of this state, Texas. Well, we have a population that's half of that of the United States. Well, what is peculiar about Nigeria is that we constitute about 1/4 of the African population. We do joke that when there are 4 black people anywhere, particularly in Africa, one of them is a Nigerian. And when there are 5 black people all over the world, one of them is a Nigerian. And that's why I said, why have you left Nigeria? Many of us do believe, excuse me, that if your initiative does not have a presence in Nigeria, it really has no presence within the black population. We have over 250 ethnic groups, but we have something in common. The official language is English, and that's why we're able to communicate with one another. The population is almost equally divided between Christians and Muslims, and we have about 10% of the population holding on to indigenous faith. One of the things that the government has done over the last couple of years is to eliminate the debt burden of the country. The present government has paid $33 billion US of the national debt, and as of today has a surplus of $42 billion US, which is quite remarkable. What is the health status in Nigeria? When we're talking about immunization, the immunization coverage is low, and that's a situation that will make many people worry. Until recently, only 13% of children had received the recommended course of immunization, and 27% of children had not received immunization at all. With regard to infant and child mortality, it's very high, about 100 per 1,000 live births, and with an under 5 mortality rate of 201 per 1,000. When we try to compare that for the benefit of the audience to the situation in the United States and Canada, and Rwanda, which is a war-ravaged country, you find out that the figures are quite staggering and worrisome. What about the situation with maternal health? The average total fertility rate is about 5.7 per children per woman. The maternal mortality ratio ranges between 300 in the southwest and about 1,500 in the north. And 60% of women receive antenatal care at least once from a trained healthcare provider, and about 40% of women have supervised delivery when they deliver. And we also discovered that 17% of women have no assistance during delivery, and 26% are assisted by untrained personnel. Again, trying to compare the maternal mortality ratio to the situation in Rwanda, United States, and Canada. That's also quite worrisome. 800 is like a syndicated average, and that's about 40 times the situation in the United States, and about 50 times the situation in Canada. And many of us do jokingly say that delivery is an occupational hazard for women. In terms of malaria, it's a major problem. It's a common cause of death in young people. Many of them do come in with cerebral malaria, convulsion, and death. And HIV/AIDS is a major problem. Although the seroprevalence is low compared to the situation in Botswana, Swaziland, and so on, when we take into consideration the population base of Nigeria, 140 million, we have the second largest population of HIV-infected people in the world, about 4 million. So that's quite a large population base. And we estimated that about 1 million of the 4 million should actually be on treatment. I think we are probably covering just about 100,000, which is about 10% of those who are to be treated as of now. And when it comes to PMTCT, I think we are covering just about less than 5% of the population who actually require this treatment. Tuberculosis is a major problem, one, because it is difficult to diagnose, and also because many of the diagnostic facilities that are available are still the same that are being used over the years. One, there is little progress in terms of research, in putting on board new diagnostic methodologies for tuberculosis. The treatment modalities are almost the same over the years, so there is not much progress in terms of what is happening to TB. I'm sure Peter will bear witness to this. There is lack of significant progress with diagnosis and treatment of tuberculosis worldwide. And now we have an upsurge in extensively resistant TB, particularly in South Africa. And I think it's a question of time before it gets to Nigeria. That's also the situation with communicable diseases, HIV/AIDS, death, and people living with HIV/AIDS is almost been wiped off in the United States, apart from a few cases in some of the minority areas. I've been to some of the children's hospitals in the Northeast. Many of them have no new case of pediatric HIV. The pediatricians are holding on to 15, 16, 17-year-olds simply because there is no new case. We see many of the young ones in Nigeria. That's the situation with TB, malaria, and polio. We happen to be the largest exporter of polio. What are the reasons for this slow progress? Well, the first thing is lack of access to immunization. For many years under the military rule, the wives of the heads of state actually took on vaccine importation, and it became a status symbol that those first ladies actually started bringing in vaccines, and it became a political issue. And many of the women, the families actually objected to being immunized. So that became a problem. And then we have short supply of vaccines. We have misconceptions about the oral polio. There were rumors being spread, particularly in the north, that the vaccines were contaminated with anti-fertility agents. Many of the families just objected to being immunized against polio. So it took quite a lot of effort to get families to accept polio vaccine. The situation has been contained, and many of them are now accepting polio vaccine. The other one is the issue of poor diagnosis, lack of vaccines against some of these diseases, particularly malaria and HIV/AIDS, poor case management, and poor maternal health. When the mother dies, the baby is also likely to die. What about maternal mortality? We're talking about lack of effective family planning services, poor acceptance, lack of antenatal care, absence of clean and safe delivery, lack of emergency obstetric facilities, discriminatory social practices, too early, too late, too frequent pregnancies, unsafe abortion, and poverty. These are the driving factors that tend to keep maternal mortality ratio high in many of our segments. For HIV/AIDS, there is increased awareness, but there's been little or no behavioral change. Stigma is still a major issue, and many of us happen to see quite a number of women. About 70% of our clients are women, and we ask them questions, where are the men? They're either dead, and you now have a new wave of husbands who are HIV negative. And we think that will probably lead to a second wave of the epidemic, because these men are likely to get infected. Their wives keep on to the diagnosis. They don't want to disclose. And many of us are at the dilemma. What do we do? If we disclose to the husband, they will be sent out of the homes. We try to promote barrier contraception, but that may not be the solution. We have limited access to affordable ARVs, and HIV counseling and testing centers are not many. There is the high cost of tests for a long time, and then limited use of condom and the lack of vaccine. Malaria will also suffer from the same lack of vaccine. Anti-malaria resistance, about 70 to 80% of malaria cases are now resistant to chloroquine. So chloroquine, the cheap, time-honored drug, is no longer effective. And then limited use of bed nets. Many of the corporations are promoting bed nets. But I believe that in situations where people sleep on the floor, I wonder where and how you will make use of the bed net. And there is also lack of effective diagnostic tool. TB will suffer from low detection rate, lack of vaccine, and co-infection with HIV. About 40 to 50% of our HIV people or HIV-infected people are co-infected with tuberculosis. So it's a major problem when we talk. In terms of innovative solutions, this is like a marketing manager coming to say these are the range of problems that we have in our setting. The situation in Nigeria is not likely to be different from any other African countries. So what we are saying is that we have this problem. We've identified the MDG goal. We have the statistics. How can we address some of the problems? For the students and the scholars, we've also introduced some possible solutions. And what we now expect is that people will go to work to address some of these problems. About 11 million children die annually before reaching their 5th birthday. We know that. What are the relevant biotechnology solutions that we think will address this problem? Molecular diagnostics, vaccine and drug delivery, recombinant vaccines, female control over STIs, nutritionally enriched food crops, and combinatorial chemistry are some of the solutions. About the same for maternal death. 500,000 people die every year. 99% of them are in the developing countries of Latin America, Africa, and Asia. And that translates to about a jumbo jet carrying 250 people crashing every 4 hours. But nobody pays attention to them because they're the poor people. They are not well known. There's no obituary about their deaths. And that's why there's been little or no attention. The same model initiative that was launched by the Global Partnership in 1987 has not really addressed the problem. In a 10-year review of Sri Lanka, in fact, the maternal mortality ratio in many of the African countries had gone up by 15%, rather than achieve a substantial reduction of 50% in 10 years. So we have the problem of maternal mortality ratio. But we still think that we could address the problem of maternal mortality ratio by looking at a vast array of these issues like the diagnostics, vaccine, recombinant vaccines, female control over STIs, and so on and so forth. And the same thing will go about TB, HIV, AIDS, malaria. These are the big killers in many of our settings. And when we also try to look at the existing problems, the existing diagnosis not adjusted to situations in developing countries, many of them are expensive, they're cumbersome, time-consuming, expensive, and sometimes inaccurate. And we need technology that is simple, rapid, relatively inexpensive, and have a high sensitivity and specificity. Early detection, timely intervention helps to prevent spread of infection, and we need to avoid waste of resources. By the time Mitchell came to Nigeria, I'm sure there was power outage many times. So the situation is quite different. The solution will have to be locally attractive. It must be adaptable to the situation. Otherwise, it will not work. The same thing, we're looking at rapid tests, things that we can use to make diagnosis for HIV/AIDS, including detection of viral load, CD4 count. How can we make diagnosis of pediatric HIV infection? By point-of-care diagnostics, things that can be done outside the formal laboratory set, maybe on the bench, on the table. These are things that we require to make an impact and to reduce or stop the spread of many of the infections in many of our settings. The same thing for the infections. We will need novel approaches to address them. We're talking about malaria subunit vaccine. I was particularly interested about the vaccine for malaria. I hope we'll get it one day. So also will be the approach to combat the influenza virus. I think we should not wait until we have actual human-to-human transmission before we make an effort. The current approach is to say, oh, you must cull your birds, is also not going to be attractive. The farmers are being compensated at a rate that is far less than the cost of the birds. And so what we then have is a situation where even when there's an outbreak, they are not likely to disclose the occurrence of an outbreak. And we just have to keep on hoping that even though we might have a few bird-to-human transmission, we will not have human-to-human. Because when we have human-to-human, the impact of the epidemic will be far more disastrous than that of the HIV pandemic. So it's also the same for infectious diseases, reduction of maternal mortality. The current problems, the improved drug delivery, improved methods of vaccine production and so on. And we need products that are temperature stable and some control release formulations and so on and so forth. And we need to tackle the effect of hepatitis and so on. That needs to be mentioned, that quite about 10 to 15% of the HIV-infected individuals are also co-infected with hepatitis. And we have hepatitis actually infecting many more people than TB. So we need to talk about sequencing. These are for the students to say, what can we work upon? The problems, the type of drug delivery, type of vaccines that we think will be appropriate and, for our setting are all listed here. All listed. The next one or two slides, we will also talk about the guiding principles for biotechnological innovations. One is that whatever we are going to take to Africa must be sustainable. Anything that is not sustainable will be a flash in the pan. Work for 1 or 2 years. You come back the year after, it's no longer available. It must be appropriate. They must be able to function under very high temperature. The refrigerator may not work. Electricity may be very unstable. And so if you are planning to come to Africa, and I think it's, someone said when you're coming to Africa, how should it be? The thing is that in many of our settings, we are very friendly. We want to receive our guests. We want to take care of them. But then you must have a mindset that when you are leaving US, please leave US behind. You can never be sure of power. You can never be sure of anything. But at least we'll be sure of the hospitality of the people. And we also talk about our most available commodity, as that's the sun. And that's God-given. We do not have winter in many of our cities. There will be winter in South Africa. It must also be affordable. We cannot take away cost out of our consideration. It must be something within the reach of the ordinary people. And many of our people are willing to pay for health care, but the cost must be within reach. Those who actually evade payment are those who have money. That's my experience. Those who are poor, they want to pay. Sometimes they tell you, can I leave my land as a security or something? So they value health and they want to pay. The affluent ones don't want to pay. It must also be user-friendly. When it's too technical, very complex, like some of the complex gadgets that Rebecca sent to us in Nigeria. We might have the difficulty operating them. So it must be simple, very user-friendly. And we must also talk about partnership. I think what is unique about your meeting and your program is that it's being built on a foundation of partnership. Partnership between people in the academic community, the private sector, in the industry, in government, all working together for the common good. And this is why your program is unique. There should also be market-oriented research. Is this product going to be of value? If we do not do that, you might find out that there will be nobody to use your technology. I also added wealth creation. whatever you are bringing must be able to build wealth, both for those who are supplying it and those who are going to use it. There must be mutual benefit to everybody. When we see health as wealth, then that is also benefit. It doesn't have to be really cash. And we should stop seeing health as a social goal, but we should see it as investment. And then when you supply something that is going to promote people's health, then you're building wealth within the people. How can innovative biotechnology solutions help to accelerate the achievement of MDGs in developing countries? One is that it will help to understand the pathogenesis of diseases and identify the risk factors. It's going to help us to develop better tools for diagnosis. It's going to help us to develop tools for control of the vector to interrupt disease transmission. It's going to help us to develop novel drugs that are safe, effective, affordable, and easy to administer. It's also going to help us to develop better tools for monitoring resistance to drugs and insecticides. It's going to help us in the determination of better understanding of protective immunity and to identify the targets for protective immune responses for effective vaccines. The biotechnology solutions that are capable of accelerating the achievement of the MDGs will include molecular diagnostics, recombinant vaccines, vaccine delivery systems, bioremediation, sequencing pathogen genomes, female control protective devices, bioinformatics, nutritionally enhanced crops, recombinant therapeutic proteins, and combination chemistry. And I'm ending the presentation by saying that when there is an effective national response, there is strong political backing at the highest level, quite a lot can be achieved. And I think we are benefiting from that in Nigeria, particularly over the last 8 years. I want to thank you again for giving the minister an opportunity. I'm sure he's still going to come back. I'm going to also request that when he's here, in a couple of weeks, he should also visit Baylor and see what Mark is doing. I think that would be a wonderful experience. Thank you.
In this country and in the state, there's been a lot of talk about human papillomavirus, and that in fact, when and if a human papillomavirus vaccine is disseminated and testing is done on males, some of the issues that Amrita raised and then you asked questions about will go away in some regards because at least the transmission of disease might be ameliorated. In this country, there's been an effort to develop programs around male responsibility. And I wonder if in Nigeria, in the face of an HIV/AIDS epidemic, that it looks the way it does, has the issue of male responsibility been one that has been discussed in health circles?
Thank you. Now I'm no longer the minister, so it's quite interesting. The issue of male involvement has been a major issue, particularly in a setting. Without the man, the woman is not too powerful. I don't want to say helpless because that would be completely negative. But the male has a strong presence. It's a male-dominated society, and we need men to do many things. When we started the contraceptive promotion programs initially, we were asking for the women to obtain the consent of their husbands. That was quite ridiculous, but we wondered why we were doing it, until we discovered that the women were going out of the hospital to hire male security at the hospital entrance to come and act as proxies for husbands. So the men were coming, and we discovered that they were being paid to give consent, and we then had to stop it. For HIV/AIDS, we are doing many things to reach the men. In some of our programs, we are writing what we call love letters to the partners. We're trying to promote male attendance. please come with your wife just to have a look at what we do so that you can have better understanding of the situation. These are likely to help, but I can also assure you that in many of the situations, the response has been poor. Because there is the issue of the male ego. And men don't want to take responsibility. When the woman is infertile, the man automatically assumes that it's the wife that has a problem. And we tend to mix up the issue of potency with fertility. And you find a Nigerian man saying, oh, I can have intercourse with 4 women at a time. But that's not the same thing as fertility. So we've not made significant progress, but we recognize that male involvement is something that is very paramount. And we need to promote this virtually all sectors so that there can be peace. Not only at home, but we see men as partners in progress. So we're doing that. But how much success we made is difficult to quantify as of now. But many of our programs are targeting men. And there are male programs all over to get them tested, to let them recognize that women are important, they're stakeholders, and so on and so forth. Unfortunately, we have quite many of the female legislators who are promoting this. Female senators, members of the House of Representatives at the national level that are actually promoting women empowerment and also trying to make men to recognize women as co-partners.
How strongly do you really feel that biotechnology and increase in biotechnology is going to help Nigeria or any developing country when, I mean, you said yourself earlier, good governance you think is key to a lot of these issues, and when, I mean, we've seen in Nigeria, Muslim leaders told their communities that the polio vaccine was to a horrible purpose like sterilization or death, and whole communities overturned vaccination programs, even though you had the vaccines, you had the personnel to give them. So how strongly do you really feel that what you need is biotechnology rather than programs that are going to integrate the existing biotechnology into the community?
Well, the first thing is to say that the currently available biotechnology are inadequate to address the issues on ground. So we need more. My comment about good governance should not be seen as being exclusive to having newer technologies. I said that because 80% of the problem that we have in Africa, many developing countries, are due to inactions or inactivities of government. When we have water, we have electricity, we have food, we have education. Many of those communicable diseases will disappear. But it's not going to make cancer disappear. It's not going to make many other. In fact, we are likely to have an upsurge of many other newer diseases. People who are now wealthy, like in China, might start smoking. People might start consuming more alcohol. So you might have some other emergent diseases that will also require new approaches. So they are not mutually exclusive. And the society is also not impervious to newer technologies. But still, for things to be effective, for people like Mark to have effective engagement on ground, there needs to be a good government who will protect them, who will make sure that things work, who will make sure they have water at the pediatric clinic in Gaborone, who will make sure there's power, and make sure that when drugs land at the airports, you don't have bureaucracy, they're allowed to be cleared properly and taken to the sites where they're needed. So good governance is vital, but we still need biotechnology.